In this video, we'll discuss Guillain-Barré syndrome. Guillain-Barré is an acute, immune-mediated disorder that affects the peripheral nerves, leading to muscle weakness and paralysis. In this disorder, an abnormal immune response damages the myelin sheath surrounding peripheral nerves. Normally, myelin, which is produced by Schwann cells in the peripheral nervous system, is a protective insulator that increases the conduction velocity of action potentials along the axon. This allows myelinated neurons to transmit signals much faster than unmyelinated neurons. In Guillain-Barré, damage to the myelin sheath impairs the axon's ability to conduct nerve signals. In severe cases, the axon itself can be damaged too. The exact cause of this immune response is unknown, but it's thought to be due to molecular mimicry, in which an infectious agent, such as a virus or bacteria, has a substance in its outer layer that resembles components found in myelin. Several agents have been associated with Guillain-Barré, but the most common culprit is Campylobacter jejuni. When the immune system detects the infection, it produces T cells and antibodies against this specific substance, which then cross-react with the myelin of the peripheral nerves and nerve roots. Microscopically, this can be seen as an inflammatory infiltrate within the endoneurium, the innermost layer of connective tissue that surrounds the nerve axon. The infiltrate mainly consists of lymphocytes and macrophages that extend from small blood vessels to the associated axon. The immune response strips the myelin sheath and most commonly affects motor nerves, resulting in muscle weakness and paralysis. However, sensory and autonomic nerves may also be involved. Patients classically present with a symmetric ascending pattern of motor weakness that develops 1 to 2 weeks after a respiratory or gastrointestinal illness. The weakness typically worsens over the course of a couple weeks. It begins in the legs, which often manifests as difficulty walking or climbing stairs, and later progresses to upper body weakness. It can then rapidly progress to involve cranial nerves, such as the facial nerve, resulting in bilateral facial weakness. It may also involve the respiratory muscles, including the diaphragm, which can lead to respiratory failure requiring mechanical ventilation. This is a life-threatening complication that occurs in up to a third of patients. In addition to weakness, patients also commonly have decreased or absent deep tendon reflexes, as well as autonomic dysfunction and paresthesia. The diagnosis is primarily clinical, but can be supported by cerebrospinal fluid analysis. CSF analysis shows elevated protein, likely caused by inflammation of the spinal roots, which travel across the subarachnoid space. Inflammation leads to increased permeability of the blood-nerve barrier and allows proteins to leak into the CSF. The white blood cell count in the CSF, however, is normal. The combination of elevated protein but normal white cell count is known as albuminocytologic dissociation and is a characteristic feature of Guillain-Barré. Nerve conduction studies may also be performed and show decreased motor nerve conduction velocity due to demyelination. The treatment primarily involves supportive care. Patients should be monitored closely in order to identify those with impending respiratory failure who need endotracheal intubation. Some patients may receive immunomodulatory therapies, which can shorten the recovery time. These include plasmapheresis, a procedure that removes the pathogenic antibodies from the blood, or intravenous immunoglobulin, which is thought to neutralize the antibodies and suppress the immune response. The majority of patients recover completely or with minimal residual deficits due to remyelination by Schwann cells and axonal regrowth. However, full recovery can take months to years. To sum up, here are the key points to remember. Guillain-Barré syndrome is an acute, immune-mediated demyelinating disorder that affects the peripheral nerves. It's thought to be due to molecular mimicry, in which an infectious agent causes an immune response that cross-reacts with myelin and Schwann cells. The most common precipitating agent is Campylobacter jejuni. Patients typically present with ascending muscle weakness 1 to 2 weeks after a respiratory or gastrointestinal illness. Weakness can progress to involve the respiratory muscles, a life-threatening complication requiring ventilatory support. Patients also have decreased deep tendon reflexes, dysautonomia, and paresthesia. The diagnosis is clinical, but is supported by albuminocytologic dissociation in CSF analysis and reduced motor nerve conduction velocity in nerve conduction studies. Supportive care with respiratory monitoring is essential. Plasmapheresis therapy or IVIG may also be used. Most patients recover completely over the course of months to years.